Good evening, everybody. It's our great pleasure to welcome you to this webinar on pharmacogenomics. This is the first webinar, which is a kind of a curtain raiser and brought to you by Haystack Analytics. The title of the webinar is Role of Pharmacogenomics in Optimizing Patient Care. And I would like to talk about Haystack Analytics. Haystack Analytics as a company we have brought several innovative products in the healthcare domain. The first of the product was on TB whole genome sequencing, which looked at the drug resistance profile across all 18 antibiotics which are used in the management of TB and using the whole genome sequencing technology, which has seen significantly uptake across several, both in across several partners. So here we've listed some of our partners who are there, as well as we have been supported by several premier academic institutions of our country, like BIRAC and DBT and Science. So with that, I am going to be your moderator for this webinar. My name is Dr. Aparna Bhanushali, and I lead the growth and scientific support at Haystack Analytics, and would like to introduce our guest speaker for the webinar today, Dr. Subhrojyoti Bhowmick. Dr. Subhrojyoti Bhowmick has impeccable credentials. He is a volunteer staff patient safety unit at WHO Geneva. Is a visiting scholar at the for Patient Safety Research and Practice, Harvard Medical School, USA. Honorary lecturer, Institute of Clinical Sciences at the University of Birmingham, UK. In addition to that, he has been the winner of the International Society of Healthcare Quality, the Lucian Leap Patient Safety Fellowship Award for 2019, being the first Indian doctor to receive this prestigious fellowship. He is also certified in patient safety from Johns Hopkins, University, USA. In addition to that, he has a PG diploma in advanced cardiology, clinical endocrinology, and diabetes from the Royal College of Physicians, UK. So before we go over to Dr. Bhowmick, I would like to state a few housekeeping rules. We would much appreciate if all your questions can be typed in the Q&A section so that which can be taken at the end of this webinar. So over to you, Dr. Bhowmick. We look forward to this interesting discourse.
Thank you, Dr. Aparna, and good evening to all the participants. It's a great opportunity to be here to share my thoughts on a topic which has been very close since last decade and which is on pharmacogenomics. And again, I would like to thank Haystack Analytics, which is doing revolutionizing work in pharmacogenomics in India. So let me share my screen and please let me know if my screen is visible. So I will begin with some bit in the history, pharmacogenetics or genomics. Why are we talking this? Is it that Haystack brought this to our information? The answer is no, because if you discover or if you talk about pharmacogenetics, this has been in discussion since the last 100 years. Today is 2024. And, especially roughly around in 1950s, we had this discussion of genomics by Arno Moltuski, he was actually a great scientist based out of Washington in the United States. And his observations were that some of the patients who received this, sedative agent and who received this anesthetic agent, succinylcholine, in the operation theaters in America, some of them had prolonged apnea, whereas others did not. So that made him make a discovery which said that succinylcholine is metabolized in the plasma by pseudocholinesterase. That enzyme is present in the plasma, but in certain people, this pseudocholinesterase enzyme is genetically deficient and resulting in the prolonged action of this drug succinylcholine, resulting in a long apnea. And if there is long apnea, these patients go into respiratory failure. They need to be ventilated. So this was the early discoveries in the 1950s, whereas this resulted in the discovery of the term pharmacogenetics in 1959 by Frederick Vogel, who is also considered the father of pharmacology and pharmacogenetics. He found out a close contact between genetics and pharmacology. Pharmacology is, of course, the study of drugs. So, pharmacogenomics is the branch of pharmacology and genetics concerned with inter-individual metabolic responses to a given medication. So, what we mean is that we are all very different. I mean, I'm talking from Calcutta, and Dr. Aparna is based out of Mumbai. I have few colleagues of Haystacks who are based elsewhere in the country. All of us actually are different in terms of our genetic makeup. Even our participants who are here from various parts of the country, we are very different in terms of our genetic makeup. Our enzymes, which are present in the liver, are the way our kidney functions, and the drugs which we take. Interestingly, if you note, we take the same dosage. I'll give this classical example of painkillers. Say, for example, paracetamol, we take an adult dose of 650 milligram. But if I am not a person who can metabolize paracetamol in the same way as Dr. Aparna does, so that paracetamol can cause toxicity in me. So one size fit all concept does not really get focused in pharmacogenomics. And there are two key terms which we need to understand when we are understanding pharmacology. One is pharmacodynamics. What is pharmacodynamics is what the drug is doing to the body, basically how the drug is working in the body. And pharmacokinetics, it focuses on four major things when the drug enters or the pill enters or the medicine enters into your body: absorption, distribution, metabolism, and excretion. And pharmacogenomics determines genetic variants in both these fields. So you can understand, ladies
Dr.
and gentlemen.
Dr. Bhowmick, if
Yeah.
I may interrupt, the slides are not
No, I
changing.
have not. I have not changed the
Okay,
slides. I'm not.
okay,
I'm
sorry.
still. I'm still spending some time on this very important slide because I believe that we'll build up on the concept on these pharmacodynamics and pharmacokinetics concept because this is the base of pharmacogenomics, that every individual differs in pharmacodynamics and how the drug acts inside the body, and pharmacokinetics is when you take a pill of paracetamol, or it could be an oral contraceptive pill, or you're taking an anti-cancer drug. They will be differently absorbed, differently distributed, metabolized, and excreted. So pharmacogenetics predominantly focuses on drug transporters, which are the cell surface proteins and the drug metabolizing enzymes, because they can differ with respect to two individuals. So I come back to the example of Dr. Aparna and me. We are totally genetically different people. We will have different drug transporters, cell surface proteins. So the drug will manifest its action completely different. On the other hand, when the metabolism will take place in our liver, there are various enzymes which are present in the liver, and the CYP family, the cytochrome P50 family, is responsible for metabolism in the liver. It consists of phase one and the phase two reaction, and the families, their numbers also differ among individuals. So the CYP2D6 family, which is an important enzyme family in phase one reaction in the metabolism of many drugs in the liver, its concentration in me might be more than in case of Dr. Aparna. So when I have more concentration of these enzymes in my liver, that can result in the drug being metabolized faster in my body than in comparison to Dr. Aparna, who has less enzyme or could be normal level enzymes. So if I am fast, if I am doing the metabolism in a faster rate, I will require higher dosage. This is the concept of pharmacogenetics. So the role of pharmacogenetics is basically to maximize drug efficacy, because we all want our patients to have the efficacious effect. We all want to minimize drug toxicity in our patients. We also want to predict the group of patients who will respond to intervention. Very important in case of oncology, because we know that in oncology, a lot of genetic factors come into play. An immunomodulator which is functioning in a particular renal carcinoma patient might not do in another patient, or in lung carcinoma patient getting a response from an immunomodulator might not get that in another. And a classical example, of course, is breast cancer, where you see there are certain genes which are expressed by certain tumors. They get better therapy with certain chemotherapy, which are targeted against those genes. And pharmacogenetics has played an important role in the new drug development. So you have to understand that this is not only theoretical knowledge, but there are literature available across the globe which says that a common antihypertensive pill like the AC inhibitors, I can name like the enalapril, 10 to 30% of patients who you prescribe enalapril will not be effective because enalapril is a pro-drug, needs to be converted into enalaprilat. And because your enzyme might be deficient, so even if you're prescribing enalapril, the hypertension is not getting controlled. Same is the scenario in case of heart failure drugs like beta blockers, and very dangerous in case of cholesterol lowering drugs like statins. Look at the statistics. 30 to 70% of your patients who will receive statins might never show any improvement because of the enzymes they miss. How this this concept is not at all theoretical. This concept is very practical because as doctors, when we prescribe, we need to know this information that many of our cholesterol patients, look at that, 70% of the patients will not be responding to the drugs because enzymes in our bodies are deficient. Enzymes in our body are not working as you think they're working. You're taking people for granted. You are taking our patients for granted that the enzymes are going to be, they will be responders. But no, there are non-responders too. So if you look at this mixed heterogeneous population in our patient population group in India also, there will be non-responders, there'll be and toxic responders. So where in those cases, we will have to treat them with alternative drug and dosage. And this is where the role of pharmacogenetics becomes very important, where we have to figure out in this patient population who are the non-responders and who are the toxic responders. So the concept of pharmacogenomics is from shifting from one size fits all to an individual care. It's more like personalized medicine because we all like personalized care. So why is it again important in the clinic? Because in 2009, there were more than 3.9 billion prescriptions dispensed. And 2021, this number has jumped up to 6.4 billion. So it is actually doubling. So of this, if you see, up to 20 to 30% of these prescriptions, ADRs were prevented by pharmacogenomic testing. So this is a huge number. So out of 6 billion, around 30%, so roughly around 1.8 billion people, adverse drug reactions. So somebody takes an anti-diabetic drug and has allergic reactions all throughout the body. There's itching reactions. So can we predict those reactions by looking at the genetic profile of these patients? The answer is yes. So 30% of ADRs were prevented by genomic testing. 99% of the patients have at least one actionable genetic variant that predisposes to increased drug metabolism. Now, this is significantly a very important information coming in that every patient which comes into your clinic, someone or the other will have a genetic variant. So you cannot just prescribe the very, very important drugs being blindfolded. And 7.6% improvement in medication adherence to the variant using pharmacogenomics as a guide treatment. So there is improvement in the patient adherence because there are for chronic diseases like diabetes, hypertension, in hypercholesteremia, if the genetic variation predisposes to ADRs, there'll be high incidence of dropout of patients while they are in your clinic. And you can prevent it by using simple pharmacogenomic testing. So if you look at the in the United States, the science is really being practiced now. So it is no longer theory. In some of the centers in India, of course, it's being practiced. Haystack has brought this to your doorstep. So if you look at the United States, around 18% of them, of the drugs which are prescribed in the US market, 18% of them have actionable pharma genes. So what it means that 2 out of 10 American patients can actually be benefited with the pharmacogenetics. Now, almost all of us here can benefit from pharmacogenomics. The countries which I've mentioned, they really look, starting from UK to Qatar to USA. Interestingly, Indian data is missing. Clearly, it shows that, the proportion carrying at least actionable genotype is do exist, means there is a lot of variation in case of genes handling particular drugs. I'll give you the example in the Indian population, CYP2C19, a very important family in for drug metabolism. It is basically deficient in the Gujaratis and in the Marwadi population. What is the clinical, or it is actually less in number, I would say, not deficient, less in number. What is the clinical implication of this? If we give the antidepressant drugs like sertraline or escitalopram, if the patient is suffering from depression, then this particular drug, because the concentration of CYP2C19 is so less, this particular drug tends to accumulate in the body and produce more adverse reactions. There'll be more restlessness produced by escitalopram. There'll be more anxiety produced by escitalopram. There'll be more upper GI intolerance produced by escitalopram, resulting in the patient leaving that drug and getting into further depression, and who knows, ending their life, because severe depression can result in suicidal tendencies. So there are various other drugs like the proton pump inhibitors, omeprazole. They also go under the CYP2C19 functioning. So if you are a normal metabolizer, then there is not much of a problem. But if you are a rapid metabolizer, your enzymes are high in number, then the drug exposure, then you will have less efficacy because there will be less concentration of drug in the plasma to act against the proton pump. Whereas if you are a poor metabolizer, you will have higher concentration of the drug, resulting in toxicity. So this is the take-home message of pharmacogenomics. There are various other drugs like codeine, which is converted into the active drug morphine, and this is brought up by the CYP2D6 family as well. In case of oncology, as I mentioned, that this branch requires a lot of genetic testing because every oncotumor is different. There's bioinactivation happens of 6-markup-to-purine, which is used in case of many cancers, and this undergoes the inactivation by the TMT enzyme. And if the TMT enzyme is normal functioning, then you will have an expected drug effect. But if this TMT enzyme is less functioning in case of a genetic variation in a patient, it will result in hematological toxicity, resulting in anemia, leukopenia, aplastic anemia. And if there is no function, it can also result in high-risk hematological toxicity. So basically, the hematological toxicity which you see with 6-markup-to-purine can be an index of the normal, not normal functioning of the TMT enzyme. So across the globe, various clinical guideline sources, whether they are the Clinical Pharmacogenetic Implementation Framework or the Dutch Pharmacogenetics Working Group or the Canadian Pharmacogenomics Network for Drug Safety, have recommended that there are genetic variation in handling drugs in our body. This has resulted in 200 clinical guidelines being published all over the world. If you look at the US FDA, 428 drugs have carried on their labels that yes, pharmacogenetic variation is present. And there are 993 drug labels overall in the world which has the annotation saying that genetic variation is possible. So genetic variation in pharmacogenes and its effect in protein phenotype has resulted in the metabolizer phenotype. So many of us are normal metabolizers. We have normal function and decrease, and there is decreased functionalities. There are some intermediate metabolizers, there are some poor metabolizers, there are some rapid metabolizers, and there are some ultra rapid metabolizers. Now, for ultra rapid and rapid metabolizers, we definitely need the dosage changes. Also, we need the dosage changes in case of poor metabolizers. I will now specifically give you example of certain drugs which are used in clinical practice, which are essential for patient outcome where pharmacogenetics needs to be tested. One of the drugs is clopidogrel. This is used very commonly after an acute myocardial infarction or to prevent further incidences of acute myocardial infarction. This drug is a standardized drug which is being studied for pharmacogenetic variation across the world. If you are a normal metabolizer, so the clopidogrel standard dose of 75 milligram is possible. But if you are an intermediate metabolizer, so we cannot start at standard dose. We might use prasugrel or ticagrelor from the other group. But what happens if you are a poor metabolizer? It is important that we avoid clopidogrel and use prasugrel or ticagrelor. And if you are a rapid metabolizer, then we will have to use, in case of considering clopidogrel, use at standard dose. Sometimes we might require increasing the dosage depending on how much, how much rapid or ultra rapid metabolizer you are. So what this information means that if your patient had a heart attack and we have put them on clopidogrel, it does not mean that the patient's re-heart attack will not happen. Similarly goes with statins. The statins are a very, very essential drugs in case of AMI patients. They are also very important drugs in case of hypercholesteremia patients. But the statins, and they have these kind of pharmacogenetic variation with respect to the SCCO1BL genotype. It influences the patient adherence to statin therapy, and this can increase the risk of statin-induced musculoskeletal symptoms. Now, let me tell you that one of the common side effects or adverse effects of statin is musculoskeletal weaknesses or musculoskeletal soreness or musculoskeletal atrophy and inflammation. This can happen if there is a genetic variation of this transporter, drug transporter, which carries which carries the statins in the blood. So there is genetic variation in statins as well. So how pharmacogenomics can help in statin dosing? If you are a poor metabolizer of this particular transporter, then we prescribe the desired starting dose and adjust doses of rosuvastatin based on disease-specific and population-specific guidelines. The prescriber should be made aware of the possible increased chance of myopathy, especially at doses of 20 milligrams. So it means that because you are a low metabolizer of this particular transgene, because you are a low metabolizer, there is a high chance of the statin to stagnate in your body and produce adverse effects. Whereas in case of a hyper metabolizer, prescribe the starting dose and adjust doses based on the disease specific guideline. So it is very important that we understand what is the genomic variation in case of this SLCO1B1 gene, in case of statin dosing. This is also seen in case of codeine and in case of opioids in terminally ill patient. Cancer pain is one of the very, it is a debilitating pain. Patients who have suffered from cancer pain and family members who have witnessed that, they know that only that pain, the terminal pain, can be relieved by opioids. Now imagine a situation that you are taking care, or you are an anesthesiologist, or you are a palliative care medicine expert, and you are prescribing morphine, or you are prescribing morphine to these patients who are suffering from severe terminal pain. But if there is a CYP2D6 genetic variation, then many a times you will see that the analgesic effect will not happen. And if there's a rapid metabolizer, then you will see that there will be toxicity of morphine, which can result in case of respiratory depression. So pharmacogenomics definitely helps in opioid dosing as well. Another very common area is omeprazole, the proton pump inhibitor in gastroenterology. We write this drug left, right, and center in our general practice, in our gastroenterology practice. Omeprazole, lansoprazole, pantoprazole, proton pump inhibitor, they act against stomach acid production. But many of us, we don't know that these are metabolized by the CYP2C9, CYP2C19, and G6PD, because these drugs are used in a host of these indication. But if there is a genetic variation of the CYP2C19, and it's likely it's an intermediate metabolizer, then you will have to increase the dose of omeprazole. If it is a poor metabolizer, then you start with standard dosing of omeprazole, pantoprazole for chronic therapy and efficacy achieved considering 50% reduction of the daily dose. So you will see in many times the usually pantoprazole is 40 milligram, but many companies in India have now come out with 20 milligram combination as well. The reason is, why have they come out with a 20 milligram formulation? The answer is lying here because you might be a poor metabolizer of omeprazole, and you are one of the commonest toxicity of omeprazole is bone weakness. There could be fractures. There could be pathological fractures over a period of time if patient has been prescribed omeprazole for more than 12 weeks. So if a patient has been prescribed for omeprazole for more than 12 weeks and you are prescribing the high dosage, whereas the patient is actually a poor metabolizer, this can result in toxicity. So we need to reduce the dose by 50%. So there are various fields of medical sciences where pharmacogenomics has been used. And I'm not going to get into details starting from cardiology to neurology to infectious diseases to pain management. I just gave you a few examples. I mean, every week we can have a haystack can actually have a session on the pharmacogenomics role in these specialties, and this can go on for the next 3 months. So I think the people, many of my clinician friends then ask, who are the people who should get tested? Is it for everybody who's coming to the clinic that we get the genomic testing done? The answer is no. It should be done for high risk medication drugs. It should be done for risky situations where the patient's drug therapy cannot be taken for granted. These are the patients who are under treatment in cardiology, in oncology, in neurology, in pain management, in gastroenterology. Patients with a history of medication-related adverse events, they should also undergo the pharmacogenomic testing. Patients with history of poor response to certain medication. I'll give you an example. That patient was an old patient of AMI, and patient was put on clopidogrel. After 4 months, patient again had an AMI. So this is a big question on why the patient again had an AMI after being given clopidogrel for a very high dosage, and he's on antihypertensive therapy. Patients' cholesterol level are relatively on the higher side. Does that mean clopidogrel actually could not prevent the platelet aggregation and has resulted in this major cardiac event? Patients who are on multiple drug regime, they must undergo pharmacogenomics therapy. And again, the example I started off with, so that in case of anesthetic agent, scoline is an anesthetic agent, which this apnea is very dangerous. If you have that apnea while you are undergoing the surgery, then you had it. You will be on ventilator for a pretty long period of time. So I would again, come back to the examples in cardiology. We have got, multiple data from clinical trials. This is a paper published by Classens and group in the New England Journal of Medicine, where around 1,242 patients were divided. They were in the genotype group. The investigators knew about the genotypes, and the other group was 1,246 patients who were in the standard treatment group, but they did not know the genotypes. And the genotype testing was done for CYP2C19, and the non-carriers received clopidogrel. The carriers received ticagrelor or prasugrel. So what is the meaning of this is clopidogrel was given to this 1246 and carriers were given ticagrelor, which is in case of the genotype guided group. And we actually see that people who were on the standard treatment group, their incidence of major cardiac event where genomic testing was not done was much more. This blue line is higher than the red line. Genomic guided testing, they had lesser incidence of re-heart attacks than the one who had the who than the people who were not tested. So if you're not testing and you're just blindly writing the medications which are high risk medications in this primary angiography patients, you are actually taking a big risk. Again, I would say that in neurology, there has been 29% increase in referrals of the first suspected episode of psychosis, more so in case of the psychiatry patients from 2019 to 2021. And there are various causes for it. And I'm not going to get into those, but what is the most important thing is antidepressants and antipsychotics have been prescribed. Now, not only the psychiatrists prescribe this in India, antidepressant, antipsychotics are prescribed by the GPs, by the physicians. Sometimes I've seen gynecologists also prescribe this. But what we don't know is that they undergo a metabolism by the cytochrome P450 enzyme system. So it is extremely important that pharmacogenomics guided therapy is brought about for giving these medications because they can optimize number one medication selection, they can do the psychotropic regimen tolerability improvement, and there is a adherence to the treatment and likelihood for therapeutic success. Because in case of these antidepressant pain, in case of depression and psychosis patients, if they lose their medications or if they lose their interest in taking medication, if there is less adherence to this medication, then there is a high chance of relapse, and sometimes this can result in suicides as well. So it's very, very dangerous. So there's a preemptive pharmacogenomic testing can prevent adverse drug reaction, and this has been seen in case of these patients which have been on antipsychotics and antidepressants, and clinically relevant ADRs in 21% in the study arm versus 27% in the control arm, meaning that if you genetically determine their genotype, so the ADRs are definitely less in the study arm vis-a-vis the control arm. There is 41% less hospitalization in the genetically decided patient population and 40% less readmission. Now, this is a big deal because, if the psychotic patients they get hospitalized, there's a high chance of suicide in those patients as well. So, and there's a cost of therapy which increases. So, there's a financial implication cost, there is a social cost which can be reduced by pharmacogenomic testing. So I think precision medicine is here to stay. Precision prescribing is more crucial than ever. And this branch of pharmacogenomics, it will determine how genes affects person's response to drugs. And in a country like India, which is 30 nations together, our Jammu and Kashmir is very different from Kerala. Our Bengal is very different from Rajasthan. Our Assam is very different from Maharashtra. We cannot go with this fact that one size would fit all, because these pharmacogenomic testings will help us tailor treatments which are not only effective but also safe for individuals. There'll be enhanced medication management and tolerance. This is definitely going to improve the patient outcome. And as I lastly mentioned, it is going to be cost effective because in a country like India, which is a middle income country, every penny counts. So if it is cost effective, then definitely it is important to do this. Dr. Aparna, do you want me to speak on this or you would like to take it from here?
Thank you, Dr. Bhowmick. That was really, really a very insightful presentation, brushing across the concepts of pharmacogenomics and then giving us some real life cases, very interesting indications of patient experiences that you've had, as well as the utility and benefits of pharmacogenomics. So I would just like to talk about the pharmacogenomic solution that we have developed at Haystack Analytics. So the pharmacogenomic solution that we've developed, the pan pharmacogenomics, looks across 15 categories and gives drug recommendations for almost 93 drugs. So here we've created, I would just like to show the report. Here the report that we've created, it's in a very succinct and a kind of a linear fashion, which is very easy to understand. So first of all, we've indicated the summary of results. So which are the drugs which need to be avoided, which are the drugs which are to be used with caution, and the drugs which can be used as directed. Now, the next is, so this is again a summary of the results. This is again divided into domain wise. So, like cardiology, an example over here is clopidogrel. In infectious, we have voriconazole. In neurology, we've indicated that you need to avoid or consider alternatives for amitriptyline, clomipramine, and so on and so forth. So this is how the entire, the summary of the drug is indicated based on the genetics. The next aspect is where we are talking about what are though we have indicated what are the drugs which need to be used with caution or so on. The next part talks about what are the recommendations. So these recommendations, so if you knew what are the dosing recommendations, what are the alternatives, these recommendations are indicated in the next section of the report, where it highlights that these are the drug usage recommendations. So these recommendations are based on the CPIC guidelines, and so basically, subsequent to which is the genetic information. So basically, the pharmacogenomic test, the pan pharmacogenomic test, is a once in a lifetime test where we're using the whole exome sequencing technology, and which significantly reduces the costs, as well as the fact that you need to do this test only once in a lifetime. So, with that, I would like to thank all of you for your patient listening, and we'd be happy to take any questions which are there.